Ultrasound champions, thanks for watching the video. If you have not done already, please subscribe and share the video. Happy watching! Welcome back, everyone, to another episode of Ultrasound Podcast, where we dive deep into the cutting-edge practices and game-changing innovations in the point-of-care ultrasound. Today, we are honored to welcome a true luminary in the world of lung ultrasound. He is none other than Dr. Daniel Lichtenstein. With an illustrious career spanning 4 decades and groundbreaking contributions that have shaped this field, Daniel has established himself as one of the foremost authorities on lung ultrasound. Joining us all the way from the beautiful city of Paris, France, it's a privilege to have him share his expertise and insights with us. So, without further ado, please join me in welcoming the extraordinary Dr. Daniel Lichtenstein.
Thanks, Daniel, for joining us all the way from Paris in France.
Hello.
And I believe it's a very cold morning out there. In Australia,
Absolutely.
It's nice and warm.
0 degree outside.
So, Daniel, thanks for taking your time. And the lung ultrasound is such an important topic for our practice in the emergency department that it will be really fascinating to have you on board in this discussion. In the emergency department, for example, we do the lung ultrasound quite often, whether it's suspected pneumothorax, shortness of breath, suspected pleural effusion, or even the patient who is just coming with chest pain. So over the next few minutes, we are going to talk different aspects of lung ultrasound. So Daniel, first of all, let's tell us a little bit more about this lung ultrasound that you have been practicing for over almost 40 years now. What has encouraged you to this particular field?
I will try to be short because 1 hour is nothing when you love what you say. Time is running very fast. I was always attracted with acute care, that is emergency medicine, or it ended with intensive care medicine. And I was fascinated when I was a student in 1983 by looking ultrasound examination done, I make very short. I said, but this is so easy to have an image, and the colleague has the control of so many details. What a wonderful technique. And I began my curriculum of intensivist, intensive care. But I said to myself, but we must do something with ultrasound. And at the beginning, between 1985 and 89, I was accustomed to wait the night for discreetly borrowing the ultrasound machine in the radiology department. I say it to you, don't repeat. And I went to the ICU, I saw the problem, oh, it's that, or it's this, and I got back to the radiology department. That was my first steps in life. And in 1989, I was accepted to work in the only intensive care unit in the world equipped with echocardiography, which was in my city, in my country. So I did not have to move a lot, not at all. And it was François Jardin, the pioneer of the echocardiography in the ICU. So I was there, and I could manage the patients with the use not only night but also day. And I had the freedom to apply my probe where I wanted. So it was, I saw the vessel a little bit, not only the heart, and I saw the lung. And to begin with, I said, well, there is nothing to see, but I insisted a little bit, and I said, but we have this side and this other and this other. And my last discovery on lung ultrasound was 15 days ago. So it is, it always produces something new, which allows me to simplify the things. And so I made a little work of medical intensive care and a very, very big work of research that is trying to submit manuscripts of an idea that was extremely clear and was obvious, that is using the visual guidance for managing critically ill patients. But it was much harder than I believed.
Thank you, Daniel. So you have mentioned that the lung ultrasound is a part and parcel of critically ill patients, whether it is in intensive care unit or in the emergency department. And you have got multiple publications on this. What are the uses you find in case of the lung ultrasound in critically ill patients? Is it in shock? Is it in somebody coming with breathlessness or anything in particular?
When do I use my ultrasound machine? I would say all the time. It's not a disease, but I scan my family to begin with. They are very healthy and I want them to keep healthy. So if I have to see something before it makes clinical signs, why not? I give one striking example, aortic aneurysm, for instance, or kidneys and plenty of things, breast. I scan the patients in my specialty, that is the critically ill patients, for circulatory reason or respiratory concern or any other concern. I scan the patients that I manage during my medevacs, that is airborne evacuations of patients. I scan them because I need to see what is at the beginning of the mission and what can occur when we are above the ocean. So I scan everybody. Ultrasound is not dangerous and you can use it provided it is clean. That's a problem. If we have time to speak of that, if ultrasound is clean, I can use it without any harm to the patient. And if ultrasound does not distract me for managing the patient, I use it. If I lose time by trying to see the segmentation of the liver and the patient is in agony, it should be a misuse of ultrasound.
Mhm.
I think I answer shortly your comment.
Yeah, there's an excellent explanation of the uses of ultrasound in critically unwell patients. And one of them is obviously the pneumothorax. And sometimes the pneumothorax can be missed in an X-ray, for example. That is when the ultrasound comes into play. What is your experience or what is your thought about the ultrasound in occult pneumothorax patients?
So this paper was, to my opinion, a minor paper, but it was surprisingly not too difficult to publish. It was rejected a few times only. Usually my papers are rejected, not me. All the doctors who want to publish have the same problem, but publication is my only way of existing. So for me, it has a major importance. And we deal with the pneumothorax, which is a disease that is very benign, that is very easy to treat, and it can kill. So it is, for me, one major application of ultrasound. My clinical examination with my ears and my fingers are not always perfect, especially when there is plenty of noise. And in an airplane, there is nothing but noise. And so I wonder how I could make a diagnosis of a pneumothorax. The X-ray, not in an airplane, but even not in a hospital, in the extreme emergency, cardiac arrest. And when you have the X-ray, it misses pneumothorax in a big percentage of cases, from 30 to 40%, according to Tocino study. She studied traumatic pneumothorax between 30 and 40%. Are you happy? No. So ultrasound is a discreet and elegant way to immediately have the answer. Okay, here there is no pneumothorax, here there is no pneumothorax, or here there is the A prime profile, so likely a pneumothorax, and I scan for the additional side. It's routine, and you can do that to all the patients that you deal in internal medicine, cardiology, pulmonology, nephrology, pediatrics. There are 17 disciplines where the word pneumothorax is possible concerned. Did I answer your question?
Thank you very much. That was brilliant. And of course, when it comes to the lungs, we have the pleural space as well. So there can be pleural effusion, there can be pneumothorax, there can be empyema. When the lung ultrasound can be useful to detect those pathologies. What are your thoughts about that?
It's very basic. The pleural effusion was discovered before me. Pleural effusion was André Denier, 1946. And after some people from North America did that, my training center, the SURF, teaches pleural effusion, fluid pleural effusion in a specific way. We do not use signs that are used by the usual schools. And I find it of high importance. Pleural effusion is not a disease. It is a disease when, in the case of a malignancy, when you have 10 liters of pleural fluid, or when you have a venous line in the subclavian vein that makes glucothorax. But pleural effusion fluid, for me, is just a condition that comes together with pneumonia, or hemodynamic edema, or pulmonary embolism. I do not treat a pleural effusion, I treat the cause. And so empyema, you can see that with ultrasound. But even if you have, it happens, a dark pleural effusion, I see a patient with a bit of fever and shock. I insert a needle very, very easily to check that the pleural effusion is maybe an exudate or a frank infection. So I do that very easily, of course. I hope everybody.
Thank you, Daniel. So whenever the lung ultrasound is done, we have got lots of different signs, and they are very useful. Some of them are artifacts, and some of them are just some natural ultrasound phenomena. One of the signs that I often find is this bat sign, which is the sign of the pleural lines. What are your thoughts about this bat sign? Can you talk us through a little bit more, Daniel?
I see that you have put a very pleasant bat. I was in Sydney when there were the giant bats, plenty of bats in the gardens, and so you have a beautiful species. And I see that you have an abdominal probe, which is not exactly the microconvex probe that I advise for the whole body, but we will speak of that. I always say to the community, not all of you have the magic universal probe, but the best compromise is the abdominal that I see here. And it has a sectorial technology, so I can see rather easily the ribs and mostly the rib shadows. I can see my pleural line, which is half a centimeter below the rib line, so I can see it clearly. I see a repetition of the pleural line, which makes an A line. So I can say, I suppose that we are in the thorax. This can be visible also at between two ribs. Can be the stomach, the colon, pneumoperitoneum. But I suppose we are in the thorax. And it looks like A or A prime profile. That is, this can be you and me, or it can be somebody with a pneumothorax in this image. But I must say that the acquisition is fine. The pleural line is horizontal. It is something 1 millimeter thick, and it looks to be 25 millimeter long or large, I don't know, from rib to rib. So it is a good standard, good quality imaging. Because I can interpret it. Often people show me images, I say, I cannot say one word. Here, I can.
And one of these, another important sign is the lung sliding sign. So this is one of my patients I have seen a couple of years ago. And as you have rightly said, that there is a rib and there's a lung sliding. And this is the M mood sign where there is this seashore sign.
Excuse me.
What are your thoughts about this lung sliding sign and the seashore signs?
Well, so I will comment. So here you have changed your probe. I see that now you have a vascular probe. I would be very happy to have only one ultrasound machine with a vascular probe, better than nothing. But I think that the vascular, I would say, linear probes are not ergonomic because we are not linear. Here, we are lucky to see anyway an image that I can interpret, and I see rib, and I suppose half a centimeter below, I see the pleural line, and this pleural line exhibits motion. So I can say clearly that this patient has no pneumothorax at this area where the probe is applied. And I am a bit sorry to say that, but if you are at the anterior thorax, the vascular probe will fit. But if you want to search because the patient has a chest pain or must be transported with mechanical ventilation on above the ocean, I would search for a apical small pneumothorax, and vascular probe will never reach the apex. And here I begin to say, I'm not very at ease with that probe. Oh, do you want the abdominal? It will be too long, too large. Oh, do you want the cardiac? And I answer, it will not be with that resolution that I can see in your image. And they say, what do you want? And I will say, I want a microconvex probe. We don't have. I say, do you have an endovaginal probe?
Mm-hmm.
They say, okay, I come back, I go at the gyneco department, and with such probes, I can put my probe at this strategic area and say, there is definitely no pneumothorax, or there is. So I don't go into detail. I see at the right image that it is not is the opposite of it is. It is not the standard of SURF, my teaching program, because here, the first point, I cannot interpret this image, and this patient has maybe a pneumothorax, maybe not. The two images in our standards should be side by side, not up down, but side by side, and not, as I see in 100% of cases, with a strange lag. If you see by, where should I go?
Yes.
Voilà, a strange lag. They are not exactly side by side. And when everything is fine, when the patient smiles at your jokes, it's okay. But in the case of very severe dyspnea or even a cardiac arrest, it should be a concern. So here, I have to guess where is the pleural line.
So there's a pleural line here.
I trust you.
And I believe the pleural line is, I think this is difficult to say, isn't it? So probably that's
difficult to say. That's what I wanted to hear.
Yes.
Here it begins to be a bit difficult. So I have, don't forget, it is 3 o'clock in the night. I am terribly tired, and the patient is about to make a cardiac arrest. In this situation, I have to guess where is the pleural line, and these things, these questions, these terribly angoissant, these scary questions do not occur when the manufacturer, and I see that you have a famous manufacturer here, has the idea to put the two images side by side. You see, from left to right, this is the pleural line. I say that since 35 years, and I will repeat it as far as I need to repeat it. So here I begin to have some embarrassment, just for the reason now I go to the left. I see that the patient is not comfortable. The patient has a kind of, what's the English word? Difficulty to breathe.
Breathless.
Here, put the muscles.
Mm.
And when you recruit the muscles, here I can see the two movements, the muscular movement and the lung movement. But when the dyspnea is very intense, you cannot. And so the M mode must be very well designed, and I mean very simply designed. To put two images side by side is not a great technology. They did that in my Hitachi of 1992. So here I begin to have some difficulties. And really, joke apart, I see that the upper line is probably an aponeurosis. The second line is another aponeurosis, and downstairs, I guess where you are with the red laser is the pleural line.
Mm.
And the dynamic which is below and above is, for me, similar. Not for me, because I have 35 years of looking at this, but the young doctor that will save my life or my family's life or not will be younger than me. And they will have some difficulties. Here I must use science. It's a bit complex. So definitely I should say politely to the manufacturer, please make your machine as my 1992 Hitachi.
Excellent suggestion. That's an excellent suggestion. I think if we put these two images side to side, then we can correlate exactly which one is a pleural line and which was a lung, which one is a muscle. I think that is an excellent suggestion. Thank you, Daniel.
I'm sorry not to be categoric, not to say there is pneumothorax or there is pneumothorax. Other people will be categoric, but not me. Here it can be both, and this is why it's very good that you show me this image from me to you, but because of my 35 years, I would say there is no pneumothorax. Likely. I would not be 100, but only 99%, which is not sufficient. So younger doctors will be less accurate.
Thank you. And obviously, if we incorporate the patient presentation and this clip on the left side with the M mode on the right side, probably more likely that there is no pneumothorax in this patient.
I would even say that I just need real time. The M mode in this example is not mandatory because I see the two ribs. I don't like vascular probes, but I must be fair. I must be honest. I can see the two ribs, I can see the pleural line, and I see clearly that there is a lung sliding.
Yes.
And just with real time.
Excellent. And obviously, when there is lung sliding, to exclude pneumothorax, the opposite is if there is no lung sliding, or if there is a lung point that is more suggestive of pneumothorax. And what are your thoughts about this, Daniel?
You said when there is no lung sliding or when there is a lung point, what was the sequel? There is a pneumothorax.
If there is a lung point that is suggestive of a pneumothorax.
The lung point was in 2000. I see 2014, but it was published in 2000. There's a mistake somewhere.
So it says that it is in 2000 within bracket.
Yes. So 24 years ago, I wrote that the lung point is specific to pneumothorax. Today, in 2024, I say not one more word. Nothing has changed, in spite of articles that show the opposite. And when I can find the time in my poor life to answer to these people, I say, read again the methodology. And maybe you will show me an example. But up to now, the lung point is, after 35 years and every day several hours on the screen, there cannot be a false positive. We have only 1 hour to deal with a very huge field. I never search for a lung point. I search for a A prime profile. Initially, that is the area near the sky with absolutely no lung sliding and only A lines. At this step, I say to myself, this patient could maybe have a pneumothorax, and I search actively for the lung point.
Mhm.
And when I find it, I say, I know why you are here, why you are in the emergency room. And if the patient says to me, I think I am dying, I say to the guy, don't worry, I take anything that cuts and I insert a needle or a cutter or what you want if the patient really begins to make a bradycardia, for instance. I will not wait for an X-ray. So lung point is for me completely specific. And you will
So
ask me my opinion in this image.
that's right. This is one of my patients I have seen a few years ago, and I thought that that's the lung point. What are your thoughts about it?
I will see the image without any emotion. I should first look at the anterior chest wall to begin with, but let us admit that this patient has the A prime profile, that is complete abolition of lung sliding with only A lines. Here, it's not typical. It may be the limit between the thorax and the abdomen. So if you know where is the pro, it should maybe answer the question, but up to now, I see this black zone is not typical at all from a lung ultrasound. Maybe I have even the feeling that I see a portal vessel at one moment that is two parallel lines, but it's very subtle. The M mode does not speak to me because we need really to have a stratosphere sign and suddenly a seashore sign. It's difficult here. I would, in this patient,
Get an X-ray done or a
for the
CT scan
technician.
done? Yeah.
Maybe you have another example, but here I try to understand anyway the image. You see, there is one rib, and I see a horizontal line.
So that
But
is
at
one
the
rib,
moment,
and that is a second rib here.
yes,
And that's the pleural line here where there is a bit of sliding, but in this area there is no sliding. And I thought that's the lung point.
there is. I'm
And
sorry because there is no sliding, but I should see the pleural line anyway. The pleural line is the parietal pleura, and I should see it. And here there is an interruption. So you have an interesting image, by the way, but that makes me hesitate. I will not insert this tool alone. If the patient is very unwell, if I have clinical signs of asymmetry, but just giving this image, it's a pity we are far. We should be together to see the patient. The pleural line seems completely interrupted and replaced by nothing. Maybe there is not enough gain, I don't know. I should be cautious. If I have time, maybe I will find some. I did not prepare images of the signs of lung ultrasound. I prepared 4 or 5 slides on general things, but I did not have specific images. What I see, don't move at all. Do you see my arrow here?
no, I can't see your arrow now.
So put your red laser and just let yourself be guided. Put it a little bit left. Don't move at all. Here there is a white area of maybe half a centimeter, and I suspect that this is maybe the lower end of the lung that will cover the liver, maybe, unless I am completely wrong. I am sure that there are filters in this image. And the filters hide the very dynamic of the living. That is, every vital organ moves all the time. That is heart, lung, vessels. Did I forget vital organ? GI tract. All this organ moves all the time, and the respect of the dynamics is terribly important. Can you take away the laser? I try to see again. And here I think that there is a filter. The name of the filter is maybe persistence or dynamic noise filter, or maybe harmonics. There are 1,000 names because these people are very strong for making money, especially these people. And it's difficult for the doctor to know. What I suggest to all the doctors of the world, when they buy an ultrasound machine, they should say to the technician, please, I give you my good money. You are a very, very rich man. I respect you for that. But can you make a setting with zero filter when you initiate the machine? When you have no time for making a setting on a carotid or urology, etc., when you have a cardiac arrest, can you make the setting with zero filter on ignition? If he says, no, I don't want, I will say, I don't buy your machine. I will call your concurrency, and it's terribly important for us. We are not radiologists. So here, I repeat, I am embarrassed. It's not so simple. If I show you, if I have time, you will say, okay, here I see the difference. And I have, by the way, a slide that will maybe you will see.
Okay, let's move on to the relatively common findings. One is the A line or A profile and B lines, which are very useful in the patients with critical annual illnesses, for example, breathlessness. So in this slide, we have got the examples of the A lines and the B lines. Please talk us through a little bit more about it, because these are so fundamental of lung ultrasound.
You ask me a question? What is the question?
So talk us through the importance of the A line and B line in lung ultrasound.
What is the importance?
Yes.
I will be schematical. In lung ultrasound, A line means that below the pleural line, that is below the parietal pleura, there is air, gas to be more inclusive. That is the gas of the alveoli, that is the lung is at the chest wall and well aerated, or the air of the pneumothorax. So A lines mean air and zero fluid, or maybe 0.5% of fluid. That is the fluid that is in the
interstitial space.
That's it. To the right, I see that there are B lines. Not only there are, but there are 1, 2, 3, 4, 5, 6 B lines. And here we have the lung rockets. So what is a B line to begin with? It's an artifact, not a parasite, an artifact, which indicates that there is a little more fluid than 0.5%, but maybe I would say the double, 1%. If there is 1% of fluid, that is like in a begin of edema of the interstitial tissue, the B line is generated with 7 criteria. Here I can see 1, 2, 3, 4, 5. I can see 6 of the 7 criteria because the image is not dynamic, but there are B lines for sure. And I recognize my babies, by the way, they are extracted from my papers. You can see it is a microconvex probe, but it's an old image. I don't know when it comes from, but I was rather young when I published this image because I did not make the medular correction, which consists in not putting the probe perpendicular to the chest wall, but a little bit outside for correcting an asymmetry medular. So anteriorly, I should target to the rachis, the medulla, to have a pleural line thinner, because this pleural line is a bit thickened, and I don't like to see that because the pleural line must never, I repeat, never be thick. And this one is a bit thick for what they call a tilting error. I think it is the radiological term. It's my baby, but the left one is more elegant. I can, what's the word? I can criticize my work. I can. And here it is image where I was younger than today. To the left, we have a standard pleural line. Nothing to say to the left. To the right, there should be a little more medular correction. Okay.
Thank you. And one of these other signs that we see often is the shred sign to detect subpleural consolidation, like a pneumothorax, not pneumothorax, a pneumonia. How do you use this? How often do you use it, or what are your thoughts about this shred sign?
I would love to find the time to publish the paper with the word shred sign, but I see that it is used by the community, so I don't need to spend useless time to see my paper rejected 10 times. What I see here is a red arrow that prevents me to see how is the pleural line at the end of the arrow, but I will try to make I will hide it from my brain. I do not see the red arrow. I can see the rib. I guess that the pleural line is this white line, and I see consolidation. But I say it and I write it and I repeat it. I think that we can delete not only the arrow that prevents me to see the pleural line, but we can also delete the word subpleural. The word subpleural is, I'm sorry to say that to the people who have created this word, but I quietly say to them that subpleural does not mean small. Here I see a small consolidation. It must be maybe 1 centimeter of circumference. The circumference or even the diameter of roughly 1 centimeter. It's a small consolidation, but subpleural. This word, I do not understand it. If I see it with ultrasound, it is subpleural. If there is a whole lung consolidation. So I think that the community must urgently understand this, suppress the word subpleural. If we deal with ultrasound, it is obvious that it is subpleural. So here, I would say it's maybe a pneumonia. If it is anterior in a supine patient, I would highly suspect the pneumonia. If it is posterior or lateral, it can be hemodynamic edema, it can be infarction or something turning around the pulmonary embolism. The only thing that I can say, wait a second. This image is not heavy because there is only one cycle and it makes the image move like this every 2 seconds. I can see only one breathing, and it prevents me to assess the lung sliding, the quality of the lung sliding. I do not know where we are. That is, are we near the abdomen? If yes, the lung sliding is impaired. If we are near the apex, lung sliding is acceptable. So it can be a pneumonia or anything else. And I see also 1 or maybe 2 B lines. So it is a alveolar interstitial syndrome according to the nomenclature of SURF. Alveolar interstitial syndrome. What is the diagnosis, you know?
So with regards to the presentation with fever, shortness of breath, and the ultrasound finding, it was diagnosed as pneumonia.
Yes, fever is a very important side. And we can see the shred side, that is the upstairs, the pleural line. I cannot see it clearly because of the red arrow, but the pleural line is always thin at SURF. That is 1 millimeter or less, always in all patients, all conditions. And below the pleural line, I can see a structural image, and the deep border is shredded, fractal, I say also, fractal side. And so here, it's a fluid, but intra-alveolar fluid, not a free pleural effusion.
And obviously, there is this AR bronchogram in the lung ultrasound. So this is the right upper quadrant in the mid-axillary line. So there's the liver, and there is a lung, and there is this AR bronchogram on the left side.
So here I can see that you have a cardiac probe.
Yes.
Which is the one that I would use if I have only the cardiac probe, but I always find it very pixelized first. But if I have to comment this image, I am a honest man. I say what I see. And I see clearly the liver, maybe the spleen, I cannot, but I am sure that we're in the abdomen. I am sure that we see the diaphragm. And what we see above, that is at the left of the image, is, to my opinion, ill-defined, because typically it is a cardiac resolution, cardiac probe resolution, fast array. But thanks to this airbocogram, which is dynamic, I can say, oh, it's a big lower lobe consolidation, thanks to the dynamic of this bocogram. If we had a static airbocogram, I would have difficulties to diagnose the consolidation. Now, clearly, if you use a stethoscope, you will hear the noise of the hair on your, how do you call that, the rails?
Crepitation.
You would hear crepitations here. And it looks also like pneumonia. Maybe hemodynamic edema.
So I've got another patient. I was doing a bedside echo in a patient who is coming with shortness of breath. And this is the parasternal long axis view where I found this. And obviously this was not a pericardial effusion, but a pleural effusion.
Obviously for you.
Sorry, say it again.
It is obvious for you that it is not a pericardial effusion, not for me.
There is a
yes, I guess that there is. I guess there is 1 millimeter of pericardial fluid.
Yes, very small.
Yes, where is your? But I see PLAX. That is
parasternal long axis view.
Yes, it's a cardiologic term. But right. I am very sad when I see that the cardiologists or other disciplines find difficult to distinguish pleural from pericardial effusion. And if I can speak to them as I speak to you, I would say, but put your probe at the PLAPS point. That is, I'm sorry that it looks a bit like plaques. It is the posterolateral alveolar or pleural syndrome. That is one of the points defined in the Blue Protocol. That is, you get far from the heart and you see the back of your patient. You cannot access the back because the patient is severely ill, and so in a supine position. So you try to be as posterior as you can. If you have not too long probe in this dimension, it's easier to go posteriorly. And here, when I see a pleural effusion, I see a pleural effusion. Here, if we did not have this very small pericardial effusion, or physiological fluid, I would not be comfortable. I would say, is it pleural? Is it pericardial? Because we are in the cardiologic window. What I say is terribly simple. I asked the cardiologist to get a little bit far from the heart, and it is difficult.
So there is the descending thoracic aorta, Daniel, and anything in front, that is a pericardial effusion, and anything behind, that is pleural effusion. So that is the conventional thought. What are your thoughts about that in relationship to the descending thoracic aorta?
I did not hear an important word. Say it again, please.
So in this parasternal long axis view,
yes,
here, this is the descending thoracic aorta.
Yes.
And if there is an anechoic collection deep to that or posterior to that, like here, that's the pleural effusion, and any fluid or the black area in front of it, like here, that is the pericardial effusion. So that is the conventional thought.
This is the what? Say again. This is the?
That is the usual thought.
The usual what?
Usual practice or usual understanding.
Okay. I'm sorry for my English. Yes, no yes. Thought. Yes. So this pleural effusion is possibly a pneumothorax. You tell me about the descending aorta. Maybe there was a wound with a wound in the aorta with blood in the pleural space. I don't know. Here, I do not see the whole of the walls of the aorta, but it can be an artifact of a tangency. So I will forget the aorta, and I can recognize the cardiologic convention. At SURF, for the whole body, we use the other convention. That is, the head is left, the feet are right for everything, including the heart. I never make parasternal longitudinal, enfin no, parasternal long axis views. So I always have the right ventricle at the left of my image because I use 4-chamber views, and so I see exactly where is what, and it allows me to have only one convention for the whole body. That is a bracket. I am very talkative, so.
Not at all. That's a very excellent explanation. Thank you for that. In your paper, Daniel, you have mentioned about the sinusoid sign for
Yes.
pleural effusion. Please tell us about this a little bit more.
So the sinusoid sign is not a sign of a pleural effusion. The only sign which makes the diagnosis of a pleural effusion is the quad side. That is, I see the pleural line, that is always the parietal pleura, and I see a line below, which is roughly parallel to the pleural line, which is the visceral pleura. And the two ribs makes the vertical part of the quad, so it makes a quad image. And here we can see, so the diagnosis is done already, and we just have to wonder, should I insert a needle in this effusion, yes or not? And if the answer is yes, because there is fever or anemia, things like this, I would say, okay, and then I have to choose the caliper of my needle. That is, it can be thin like this, large like my pen, and the sinusoid sign just indicates the viscosity of the fluid. The diagnosis is done already. Here I can see that this fluid seems to be easy to withdraw, and I will take the small needle. That is, in other words, ultrasound is a non-invasive tool, but even when you have to be invasive, you can be minimally invasive. And here, if I see a colleague wearing the surgical clothes and preparing a big instrument that is like this one, or even bigger, like my thumb, I would say, it's useless. Take a very small needle, you will withdraw the fluid easily. Trust me. Okay, so the sinusoid side that I could have called the piston side because it makes a piston on the real time, it's too late, is indicating of the nature of the pleural fluid.
It's more liquid. It is not exudative. It is not a empyema thoracis, you mean?
Empyema, especially if loculated, will not give this beautiful sinusoid side. Everything is thick and does not move easily. Yes. And here I would say you can take the big tube for withdrawing the maximal of fluid, for inserting lytic product, fibrinolytic product. So here I would be, liberal for the caliper of the.
So same thing will happen in case of a hemothorax, which can be liquid if it is initial blood, but if it gets clotted, then there will be no sinusoid sign. Did you mean that?
In a hemothorax? No. If the hemothorax is not yet clotted, there is a frank sinusoid sign. And in my experience, the clotting is rather late. In the abdomen, the clotting is early. Maybe because in the thorax you have a lot of dynamic that makes the fluid always moving. Clotting can be, so I repeat, rather late, but I would have, even if there is a clotting in the pleural space, I would see my pleural line, parietal pleura, and I would see my visceral pleura at a distance. The diagnosis of effusion would be done, and no sinusoid sign, meaning that the effusion has clotted and will be difficult to withdraw. And I even do not ask for a big drain, but even a surgeon to make a thoracotomy, a standard thoracotomy.
And how do you get this sinusoid sign? Did you just put an M-mode at the center of the screen?
I would say that once again, I do not need the M mode because I will see my two pleura on a real time. And if I see this piston movement,
Yes.
diagnosis of sinusoid sign is done. I was a bit young, and now I try to simplify as far as I can lung ultrasound, so piston sign, sinusoid sign.
Mm-hmm.
And I put my probe where is the fluid. I make the M mode. We have this, yes. There is no secret for that.
Excellent. Thank you very much. One of these finding in case of the pleural effusion is obviously this some ecogenic substances within the pleural cavity. Some people call it plankton sign. How do you find this plankton sign? Does it correlate with the sinusoid sign at all?
Wait a second. So the plankton sign was in my 1992 textbook. So I'm glad to see that people use it. And it signs obviously the exudate. Here it can be pneumothorax or empyema. And I am not able to see any sinusoid because we are in an area where I try to see my pleural line. I do not see it because we have a fast array cardiac probe and it is in the blurred area. No, the pleural line is, you see, upstairs, I mean.
Somewhere here.
Not really. Don't move. Now go to the right again, to the right again, and go upstairs again, upstairs again. And here I think that maybe there is the pleural line, but in a resolution that cannot be accepted when you have to take a medical decision. So this is why the cardiac probes do not have the resolution. You will have exactly the same with microconvex or even the abdominal probe. Mm-hmm. So here I can see the pleural line. I can see an image that is a structural. Within this image, there is a hectic movement, so it is easy to say that this is a fluid, a free fluid. And downstairs, I can see the rachis. So there cannot be sinusoid side. To have the sinusoid side, we should scan the patient at the PLAPS point that is a bit cranial, more cranial, because here the lung, I cannot say one word about the lung. I can just say where it is, but I cannot analyze it. So I would put my probe at the standardized PLAPS point, and I would see the quality of the pleural effusion and deeper the quality of the lung. Is it completely consolidated or aerated? So here, this patient is rather easy to manage because the location of the needle will be clearly indicated by the top of the image, and I can withdraw for bacterial analysis and for mechanical reason. I would easily withdraw this. To see the plankton like this is an indication that the fluid is easy to withdraw.
Thank you.
Impressive image, by the way.
And you have mentioned about the quad sign that the two ribs on the side, parietal pleura and the visceral pleura, it looks like a quadrangular space.
That's it.
How about the lung pulse? How do you find this? That during doing lung ultrasound, if there is pulsation transmitted from the heart?
The lung pulse is a pathologic sign that I see typically when there is a complete obstructive atelectasis, just because you want me to explain the lung pulse.
Yes, please. Yeah.
Okay. So physiologically, we have the lung that moves from head to feet all your life, and we have also the heart that beats all your life. And when the heart beats, it hurts it makes a vibration that goes along the lung. But because the lung is moving, you cannot see the cardiac vibrations. But if you stop the lung to breathe and there is only the cardiac vibrations, you will see these vibrations obviously. And you say, I see a lung sliding completely abolished. It cannot be a pneumothorax because I can see that the heart hurts the lung, and it is, so to speak, a side of atelectasis and also a side of no pneumothorax. So what I do with my students, I create a complete bilateral obstructive atelectasis, which is a pathological situation because it's just the very simple apnea is very easy to produce. You just stop breathing, but it is an unstable situation. So you can see immediately the lung pulse when you make apnea, which creates a complete bilateral obstructive atelectasis.
Mhm.
And if people don't believe me, I say to them, stay in apnea several hours. You will see that your lungs will go completely upstairs, completely white on X-ray, because all the gas of the lung go out, and you will have a beautiful lung pulse. Usually after 2 minutes, maybe in Australia you are accustomed to make diving longer than 2 minutes of apnea. Let's focus. So the lung pulse is one sign that is useful when you have abolished lung sliding, just to exclude easily pneumothorax.
So presence of lung pulse excludes pneumothorax.
Completely.
Yeah.
I see tissue-like sign.
Sorry, did you want to say something about the tissue lung sign as well?
Can you repeat your question?
Daniel, please talk us through a little bit about tissue-like sign.
Not one word, because this sign has disappeared from the nomenclature of lung ultrasound at SURF.
Thank you.
But I can tell you why.
Mhm.
Because when the consolidation is very extensive, it is obvious. We see the tissue-like sign, and it is good for young doctors because our students, they see immediately. But at SURF, we are terribly interested by the small consolidations. And as soon as the consolidation is small, it cannot express the tissue-like pattern. The term tissue-like sign prevents me to diagnose the very small consolidations. And with the shred sign or fractal sign, I prefer fractal sign. With the fractal sign or the lung sign, one sign is redundant, that is the tissue-like sign that we withdraw for having a universal definition. But it is true that this is an impressive sign. When you have the feeling to have the liver in the thorax, it's pathologic, of course.
So if there is heparization of the lung after a pneumonia, should we expect some tissue-like sign?
You said it. You said when there is a hepatization.
Yes.
So if the lung is completely hepatized, this is the tissue-like sign. I try to simplify as far as I can. I know that to suppress the word tissue-like sign will not be popular. It is just logical. So I try to be fair, and I don't prevent the people to use this term. I just say to them, with that sign, you will not be able to diagnose the very small consolidations that have a high importance in the Blue Protocol.
So that brings us to the next important topic, that is the techniques of lung ultrasound. So there are different protocols. We do it in the mid-clavicular line, mid-axillary line, and on the posterior technique is that we do it in 6 areas on the right side and 6 on the left side. Some authors say 4 on the right and 4 on the left. What is your preferred technique of the lung ultrasound, Daniel?
There are many authors, thanks God, and there are many definitions of where to apply the probe. So I will just ask one question that will make everybody in agreement. Why are you making lung ultrasound to this patient? They say to me, I want to make a loose. I say to them, okay, so put your probe in the 36 or 72 areas, make your loose, that is lung ultrasound score. I repeat, loose is lung ultrasound score. Bird in the literature peer-reviewed, so loose is lung ultrasound score, I repeat. So I don't prevent doctors to make the loose, but loose is not a diagnostic. Loose is always done in the same disease, which doctors call, I don't know why, ARDS. And if you have the diagnosis, you make ultrasound for your reason. So I don't interfere. When I see a dyspneic patient and I want to see, is it extensive pneumonia? I prefer this word. I will follow the blue protocol, and the blue protocol is only 3 points per lung. And sometimes, so it makes 6 on the 2 lungs, but some profiles need only 1 point. In other words, if I put my probe at the anterior blue point, let us say the right upper blue point, I can make the diagnosis in a few seconds, and I don't need to finish the blue protocol. I scan the whole of the patient because I am a doctor, and ultrasound, you must know how is the heart, how are the vessels, etc. You make a global assessment, but just for diagnosing, we use the 4 anterior points. If they are negative, we completely forget the lung and we assess the veins in a specific protocol that is not yet published in the peer review literature. Maybe in 2 or 3 decades I will, but it is already in my 6 books. And if the venous network is negative, I come back to the posterior lung, which is not accessible. So I scan what I can scan from the lateral-posterior areas by the technique that I said to you, that usually scares the students because they say, but why are you so cranial? I answer, I am cranial because I scan where is the lung, and the lung is not a gigantic organ. The doctors are contaminated by a color image that is in the International Consensus Conference paper, 2012, where the lung seems to be in the full abdomen. And I say, excuse me, but at surf, in this image, you can see the nipple of this gentleman. The lung will stop at 1 or 2 fingers below the nipple line. Why do I say that? Yes, to define the PLAPS point. But here you oblige me to say many, many things, and I have all my morning, but you are the master of the time.
Thank you, Daniel. That was fantastic. Obviously, lung ultrasound has got its own challenges. It may be patient challenge, the machine challenge, the overall environmental challenge. Tell us a little bit more about the challenges and most importantly, how to address them.
What challenge? There is no challenge in lung ultrasound. Tell me what is your challenge. I will tell you how to make it a non-challenge.
For example, in an obese patient with a lot of subcutaneous fat, it's very difficult to get a good picture, especially explained, as you have explained rightly, that linear probe or the vascular probe that gives us a beautiful picture of the pleura. But in a obese patient, how do you address that? How do you find beautiful images?
So people must know that this interview is completely improvised, but your question is an excellent opportunity for me to tell you that, of course, bariatric patients are a bit scary, but we practice in these patients the FAT protocol. Did you hear of the FAT protocol?
I heard about it, but don't practice this, honestly speaking.
Say it again, please.
I heard about it.
You heard it. I'm glad because it was not published apart from my books. So I use always the same probe. That is not the vascular probe. To take a vascular probe is the begin of the challenge. So my answer is, do not use this probe. And suddenly, so you can use an abdominal probe. Please, all the filters must be deactivated. To see the anterior chest wall in a bariatric patient, I will always in my short life, I succeeded to cross the fat area, and I was able to see, okay, this is the pleural line, okay, this is a lung sliding, okay, there are multiple bilides or consolidations. And so I can already make the blue diagnosis of a pneumonia, for instance, or hemodynamic edema anteriorly. If I have to scan posteriorly, the concept of PLAPS, which I cannot say too briefly because lung ultrasound is a whole discipline and time is running. I don't see time passing because I am in my field passionate. But you must see the clavicula of your patient first, and you must apply 2 hands from the patient side, and you define 1 point upstairs, 1 point downstairs, a bit more outside here, and this point will be followed as posterior as you can, and you are sure in the biggest obese bariatric patient, you will know that you are in the lung and not in the abdomen. So this is a very simple rule that I give to you for free, just to say, once you are at the PLAPS point, you will see your pleural line, and you will see if there is a pleural effusion or a lung consolidation or an image that is impossible to sharply define, but a structural image. That's a PLAPS, and you can conclude your blue protocol.
Excellent. Thank you, Daniel.
So this is one challenge solved. I love this image because the bronchi go. It's a futuristic image.
So that brings up the important topic of lung ultrasound protocols. You mentioned about the blue protocol and false protocol, and you have got multiple publications and books as well. So tell us a little bit about this basic lung ultrasound examination or blue protocol.
Well, okay, so this slide is not perfect, but we will try to use it. You want me to, I will, when I have few time, I just focus on the left arm, because the doctors who already know the left arm are different doctors. They are emphasized doctors, more powerful. We begin upstairs by analyzing lung sliding at the upper and lower blue points, that is 1 point upstairs, 1 point a bit downstairs and a bit outside. If the lung sliding is present, that is we are at the left, we search for the B lines, and if we see not only B lines, more than 2 B lines between 2 ribs, we have lung rockets. We have the sign, there is one missing word here, so it is updated now. It should be written hemodynamic pulmonary edema. You have hemodynamic edema with numbers of sensitivity specificity of 95, 97. So that, with the clinical information, you make always your diagnosis. I profit to have the microphone to say that not 99 but 100% of the teams which publish on hemodynamic edema or the blue protocol forget to analyze lung slide. So they do not use the blue protocol, because plenty of lung rockets, and doctors complain that they cannot make the diagnosis between a hemodynamic edema and what they call ARDS. And I say to them, read the blue protocol. Do you have a lung sliding? If the lung sliding is abolished, it is completely not in favor of a hemodynamic edema. This is the B prime profile that you can see a bit at the right. So I prefer to teach the hemodynamic edema just for making the doctors understanding the logic of the blue protocol. If I begin with the A profile, you can see that it is more complicated than all the others. Most of the time, and when I say B profile, it means it's not C. The C profile is a bit at the middle of the image, plenty of B lines, that is 10 or 11, 12, that makes what they call a wide lung. But if I see the slightest lung consolidation, even millimetric, I would say it's not a B profile, it's a C profile. And instead of diuretics and CPAP, it will be intubation and antibiotics. So when I teach the B profile, it allows me to teach also the other profiles. A pulmonary embolism, that is just at the right of the hemodynamic edema. People are rather uncomfortable to see a doctor diagnosing hemodynamic edema, not looking at the heart. And I say, wait, what do you want? That I make echocardiography or that I give you a diagnosis? Here I give you a diagnosis of hemodynamic edema with an accuracy 95, 97. What more do you want? But don't worry, I finish my blue protocol, I speak to my nurse and I say, give full oxygen, begin to make the therapy, etc. And while the nurse makes this therapy, I look at the heart. And what shall I see? No cardiac window, or a cardiac window insufficient, or a cardiac window confirming that the left heart has some anomalies, systolic anomalies, or sometimes diastolic anomalies that we go in a chapter which is more subtle, that I can suspect if I see enlarged walls of the left ventricle or enlarged left auricle, but we begin to go in the subtle moving sand area, and I am happy with my B profile, regardless the cardiac data. With the B profile, I want to give a message to the doctors who look the heart, but only the heart. Each time they see a cardiac anomaly in a patient who has not the B profile, I can bet a lot of money, and I am not rich, but I can bet a lot that the heart has an anomaly that is here for the decoration, but that does not participate to the dyspnea. And the dyspnea can be from another cause, pneumonia, all the other causes of the blue protocol. When I go just to the next profile, I see a patient who is dyspneic, who has, regardless the clinical data, a present lung sliding, followed by the A profile, that is at the 4 anterior points. I must give up the lung to diagnose pulmonary embolism. And the doctors will tell me, but one more time, what? Don't you look directly at the heart? And I will answer, because I have more direct, I will scan the veins. When I see a patient with the A profile, like you and me, plus area of thrombosis, venous thrombosis, the data of the blue protocol, if I read the article, sensitivity 81, specificity 99. If I have a test that gives me a 99% specificity, I consider it. And I give my instructions to the nurse. And while the nurse prepares the therapy, especially the costly ampulla of Metalise that costs a lot, I look at the heart. Usually, I will see when I have a cardiac window, enlarged right ventricle. And I will say, what shall I say to my nurse when I see an enlarged right ventricle? I will say nothing. The nurse is already preparing the therapy. And I will say it in a different sentence. All the disease of the blue protocol, pneumonia, embolism, COPD, asthma, and even pneumothorax, all these diseases create more or less an enlargement of the right ventricle. First slide, at the heart of a dyspneic patient, if I see an enlarged right ventricle, I will say pulmonary embolism, and I will give an inappropriate therapy in most of the cases. Because in the blue protocol, the pneumonia, which enlarged the right heart, as everybody knows, is present 5 times more frequently than the pulmonary embolism, more than 5 times, 82 versus 10 in the 300 patients of the blue protocol. So this is why the scientific reason why the blue protocol looks at the lungs and the veins, and the doctors who makes the blue protocol must, of course, take a look to the heart, but after the blue protocol. And I don't comment the other profiles because cannot say that even in one morning. My courses at SURF have 3 didactic days for critical ultrasound. So it is the lung.
Absolutely, yeah, that's fantastic. Thank you. Would you like to talk us about a little bit pulmonary arterial occlusion pressure?
This is the basis of the false protocol, because when you give fluids to a patient, a little more fluid than the kidney can, at the end you will make a hydrostatic edema of the body, including the lungs. And you will create, in a window that is very accessible the lungs, you will create enlargement, a thickening, edema of the subpleural interlobular septa, which creates the well-known Kerley lines that you see on the X-ray, good quality X-ray. And this is the exact equivalent of the Kerley lines, the appearance of the B line, which in a study done in 100 patients correlates with a pulmonary artery occlusion pressure lower than 18. And I can see these are my data in the chest. That is, doctors can choose I gave two limits, 13 and 18, because 18 is familiar. And if we have a limit of 13, you see that the numbers are, of course, not as accurate. So the best threshold was to consider the value of 18, which corresponds to what people use when they use the Swan-Ganz catheter, which is a bit obsolete. But you have a Swan-Ganz catheter, non-invasive with a lung ultrasound.
Yeah.
And I insist on one very critical point. Interlobular septum is thin and gets a bit edematous, a little more edematous, a very little more edematous, and suddenly the B line is generated, which means that there is a complete sudden change in lung ultrasound, whereas the patient gets few more drops of fluids. And this occurs in the asymptomatic compartment of the body, which is the interstitial septal tissue. That is, you have time to see, B lines begin to appear, I discontinue my fluid therapy. Don't forget that at the time that I discontinue my fluid therapy, my diagnosis is distributive, that is septic shock. I will turn to my nurse to make the blood test, including 4 blood cultures, which means the asymptomatic hemodynamic pulmonary edema that the false protocol has created is already treated by the bloodletting of the biochemie, the blood cultures. That is, this is a useful bloodletting. From me to you, and I have data for that, when you can begin to have your B lines under fluid therapy and feel, if you do that on a healthy volunteer, this volunteer will feel fine before feeling dyspneic. So you reach the B lines at an asymptomatic state. That's how I can at best summarize the false protocol.
Lung ultrasound can have some controversies. Do you like to add anything here?
I have maybe I will see the recent publication of my commentary on the usual misconceptions. Even the word is not easy to say. Misconceptions in lung ultrasound, where I had 2,500 words to explain 42 misconceptions. So the controversies, I wait. Show me the next slide and I will give the answer of SURF. There is no development of the controversies. People told me that there are 4,000 or 5,000 articles on lung ultrasound. I have even a crazy friend who has all these articles in paper in his house. And I saw all the piles and I said, but what can people write that was not been written 1,000 times before? And when I read a few of his papers, I see misconceptions. One, which is for me emblematic. I'm very sorry. I know that some people will say to bring the light is difficult. So people told me an Indian proverb, to say the truth is hard, but to listen to the truth is harder. So, for instance, the subpleural consolidation is a misconception. You can suppress subpleural, and if you mean small, you say, this patient has a small consolidation, and I understand what he means. The spine sign. I was in a congress and I saw the guy speaking during 5 or 6 precious minutes on the spine side. For me, each second is precious when I have to make a lecture. I did not know what was this spine side, and I still do not know. Yes, I know it is when you see the vertebrae or the lung ultrasound, but I don't use this side, which allows me during these 6 minutes to speak of important things. They say when you see the spine side, it is, you know that there is a consolidation or a pleural effusion. But if there is a pleural effusion, I see it directly. If there is a consolidation, I see it directly. So I think that there are many, many things like the curtain side, physics of ultrasound. They spend 1 hour in a congress. In a 2-day course, they spend a whole hour on the physics of ultrasound. I don't know the physics of ultrasound. It's an answer. It means that we are just users. We don't need to know it. And so you can calculate 42 misconceptions. Some of them are just illogical, some are confusing, some are wrong. So it makes the acronym wiki wrong, illogical, complicated, confusing, and inelegant concept. Voilà.
Thank you,
My way
Daniel.
to shortly answer to the controversies. Future directions.
You have been using this lung ultrasound for almost 40 years. What are your thoughts about future directions? Where we are heading to?
Thank you for this question, because it enables me to say proudly and quietly that for having a future, we need to have a past first.
Mhm.
And when I spoke of the spine side, the curtain side, and all the definitions that are wrong, for instance, the B pattern, which for me means nothing, or all the wrong definition of the B profile, the B1, the B2 profile, all these things must be, I will not give any orders to anybody. Surf just advises with a peaceful, friendly user voice that for having future directions, I have slides, but I saw an image of the B lights from somebody who want to develop artificial intelligence. And I saw the image. He's a good friend, elegant guy. But the image is taken with a modern machine. Me, Daniel, I try to see the B lights. I am unable to see them. So let us begin by the basis. That is, first, having a machine able to give the native, as they were described in 1994, B lights first, and then just know the basis. That is, there are 7 criteria. It's not a lot for a medical doctor. We are doctors, so we can learn 7 criteria. And I really think that the future directions for me are in the simplicity. Of course, to have a machine like this one is okay. I use it when I am in the medical missions, in the airplanes. But in a hospital, I think that a good trolley is much more practical. So I try to simplify. There is a lot to simplify, and this is really my message. Especially, they use 1,000 probes. 1 probe is sufficient. I must understand. I know that I am right, and I know that I am wrong, because some people do not like to hear that. To begin with, the manufacturers. Then the academicians who had the feeling that they knew everything, they are professors, so they know everything, and they see, I did not know that. So the first reaction here, it's not a question of business, it's a question of all these things are difficult to hear, and so I am ready to admit that I am wrong.
Excellent. Thank you, Daniel. Just if you can give one advice to the clinicians who are using the lung ultrasound, what that would be?
One advice. Wow.
Yes.
I said already many advices during all the webinar. So use simplicity should be my biggest advice. Lung ultrasound is simple. It is not so simple, but let us, for God's sake, let us avoid to complicate this subtle science with all these things that are uselessly complicating this science. And SURF, my training center, teaches, to my opinion, the easiest, simplest way. So what I said is that I am probably wrong from the political point of view, but scientifically speaking, I can answer to all the things that are written in the SURF courses. If people give me the time, I answer to all the questions. But business is another matter.
Excellent.
So if people want to make some business, they can invest in all these futuristic trends. But if they want to make a good scientific medicine, simplicity is sufficient, period.
Excellent. Thank you, Daniel. So you have got quite a few papers on lung ultrasound. This is for my audience to go through. And thank you very much for taking your time. And it was a very productive time for almost 2 hours now.
I hope I will meet you in your area in Australia.
It's getting a bit dark now outside. It's 9 o'clock.
Now it is 9 in the evening for you.
Evening, yes.
11 o'clock in the evening now.
9 o'clock, it's 9 o'clock now.
Okay. So maybe we have a prime minister. I will open the radio because it's today that France will have a prime minister. I know that the whole world is looking at what happens in this part of the world. Mm-hmm. And so the world is small anyway. And so if I can meet you at any event in this world or in your area, it should be my great pleasure. Maybe a medical retrieval is an opportunity for me to be everywhere in the planet.
Excellent.
So
thank you
for what you did. It was a good opportunity to say what we advise, what we do not advise. It was a good opportunity. Thank you again.
Thank you very much. And I hope that we'll see you again.
If you have any questions, by email, we can answer if there is a question for the audience. We can, as far as I have time to do that, answer by email. Thank you again.